We have with us Dr. Stephen Jones, and he will be describing the development and evaluation of a new measure of personal recovery in bipolar disorder and a new individualized psychological therapies designed to enhance personal recovery outcomes in individuals with a relatively recent diagnosis of bipolar disorder. Dr. Jones' research interests have always centered on the psychology of severe mental health problems. For over 15 years, his primary interest has been in the psychology and psychological treatment of bipolar disorder and associated conditions. In line with his interest, he has over 100 publications, mainly on the development of cognitive therapy approaches for bipolar disorder and on psychological models relevant to the development and recurrence of bipolar experiences. He is currently the co-director of the Spectrum Center at Lancaster University. The work of the Spectrum Center is focused on research into the psychological understanding and treatment of bipolar disorder, working across academic, NHS, and voluntary sector services to improve outcomes for individuals with this diagnosis. Stephen was a member of the team responsible for the recent NICE guideline for bipolar disorder and is expert lead for bipolar disorder for the UK Improving Access to Psychological Therapies SMI program. Dr. Jones, we're very pleased to have you with us today. Thank you and welcome.
Thank you, Debbie, for that introduction and the invitation to present to your group. I'm pleased that so many people have been able to attend reasonably early in the morning. I'm speaking to you from the UK, where it's pouring down with rain in the early evening, so it's rather different over here. So what I wanted to talk to you about was some work we've been doing at the Spectrum Centre in Lancaster on recovery-focused cognitive therapy for bipolar disorder, a structured psychological approach that, as with all of these things, is actually a team endeavour. So I've led the work on this, but there's a number of people who've been involved, and I've listed several of those people here who are a mixture of academics and clinicians who've been involved in the development and evaluation of this new intervention. I particularly wanted to highlight the contribution of the Recovery Bipolar SERG listed at the bottom. That's a group of people with lived experience of bipolar disorder who were involved in all stages of the work we've done on this topic, and whose input has been extremely useful in both the development and the evaluation of both the measure of personal recovery that I will talk about and also the intervention for enhancing personal recovery. In terms of the background for this, most structured psychological approaches for bipolar disorder have traditionally focused primarily on relapse prevention and to a lesser degree on symptom reduction over the long term in bipolar disorder. And those seem to be perfectly reasonable targets, and indeed the National Institute for Clinical Excellence in the UK have recently published an updated guideline for bipolar disorder that, as Debbie mentioned, I was involved in, and that came out in September 2014, which did a systematic review of the evidence on psychological interventions and concluded that there was clear evidence that individual interventions in bipolar disorder can help reduce relapse. So that's a positive thing. But then there's the question about what about other outcomes? There are other aspects of people's lives that people describe wanting help and support with, that we need to take into account. And also we need to take into account, I think, the fact that relapse isn't a binary outcome, in the sense that there are lots of different sorts of experience of relapse that people have, some of which can be potentially devastating for one's current sort of pattern of life or social network, and others of which can be at a lower level in terms of their levels of disruption, but often in terms of the academic literature, these can be treated as almost the same thing, and that doesn't seem to be helpful. In terms of recovery, there is a debate, well, not so much a debate, but there's a discussion in the literature around both clinical recovery, which is associated with returning patterns of symptoms to a similar level to those within a population without the diagnosis of bipolar disorder, versus personal recovery, which is the ability to engage in life in a meaningful way as defined by oneself, and to move towards personally valued goals. And so being able to get on with one's life and one's relationships in a way that one feels to be positive, which can overlap with symptoms and can overlap with clinical recovery, but they're not necessarily exactly the same thing. And in terms of wider mental health problems in general, and bipolar disorder in specifically, there is evidence that people value the concept of personal recovery, although I'm aware as well there is some debate about that term, and that's fine. In terms of the UK, there is the move towards recovery outcomes is quite strongly reflected in a wide range of government mental health documents, including No Health Without Mental Health, which has been very influential. However, the therapies themselves don't specifically focus on personal recovery outcomes, and there are very few measures of personal recovery out there which are reliable. So that's two challenges that we are facing in terms of thinking about how do you enhance personal recovery in relation to bipolar disorder. The other element I wanted to flag up as a context for what I'm talking about this intervention is thinking about early intervention. So this intervention is designed, or certainly this trial was focusing on enhancing recovery outcomes for people who are relatively early in the course of their bipolar disorder. And there are several reasons for this. One is that delayed treatment seems to be associated with worse outcomes in general for people. Also, later episodes, there's evidence that the sorts of disruptive events that trigger later episodes seem to be particularly strongly linked to events that had triggered mood episodes previously in somebody's experience of their bipolar disorder. One of the implications of this is that it seems that the sorts of cognitive processes, the ways in which people think about their experiences that can influence outcome earlier on, those patterns are less clear later on, which might mean that psychological interventions would be more powerful when applied earlier in the course of bipolar disorder. There is some evidence for this in terms of there have been a number of studies that have looked at the relationship between number of previous episodes and outcome from psychological therapy. And it does seem for both individual therapy and group interventions as if outcomes tend to be better for individuals with fewer episodes. Although I should clarify that those are studies that have looked within a particular trial of this relationship, and those trials aren't specifically designed to test effectiveness in people with more recent experience of bipolar disorder. So this is one of the very few trials that's actually been designed with that in mind specifically. And there's evidence also that earlier onset of bipolar disorder on the whole is associated with worse clinical outcomes. So there seems to be a number of arguments for targeting an intervention at people earlier in their experience of bipolar disorder. This in itself, of course, is a challenge. So there's a recent survey done by Bipolar UK, which is the British third sector organisation for people with bipolar disorder. It's got a large membership and runs a mixture of information giving, peer support and other resources for people living with bipolar disorder. And they ran a survey in collaboration with the Royal College of Psychiatrists. And from a sample of over 700 people, they found that time to a bipolar diagnosis for people was over 13 years. So obviously, you know, a significantly long period of time. And during that period, 85% identified having been wrongly diagnosed, mainly with depression. And over 2/3 of people felt that their condition had been made worse by inappropriate treatment, often linked to the diagnostic issue. Another factor flagged up by clinicians who were involved in the survey was that a large number of clinicians felt that they needed help with identifying and screening for mania history in people presenting for psychological or psychiatric interventions. So they're feeling that they didn't have the resources or weren't confident in the skills to actually identify this. And in terms of obtaining the right diagnosis at the right time, it seems to be important because actually the diagnosis is a requirement, certainly in the UK and I'm sure elsewhere, for accessing the right sorts of treatment in a timely fashion, but also in terms of not receiving interventions that could potentially be harmful, which the survey suggested a number of people had experienced. And also there's evidence that duration of untreated bipolar disorder itself is associated with worse outcomes in a number of aspects, including people having more episodes, higher levels of suicidality and more mood instability in between episodes. So it does seem important not only that this is detected in a timely fashion, but also that we have a range of interventions we can potentially offer people when it is detected. So in terms of recovery-focused CBT for bipolar disorder, the intention for the intervention is to provide a flexible but structured package of psychological care. This draws on the current evidence base for psychological interventions for bipolar disorder, but also draws on what we know about what people want in terms of flexibility and matching of the intervention to each person's particular priorities. It targets individuals early in the course of their bipolar disorder, with the hope that that will not only help people on receipt of the intervention, but also might have the potential to improve people's trajectory in relation to bipolar disorder over time. In terms of the outcomes that we were looking at in this trial, we looked at a number of things, but a particular focus for this trial was on personal recovery, which we identified in our own consultation work and from other literature as being an outcome which was valued by a range of service users. We did some development work prior to the trial that I'm going to talk about. So in 2008 we published data from a case series in which we'd offered an early version of this intervention to a small number of people who we worked with in great detail to identify what they thought of the intervention and also the sorts of impacts that the intervention was having for them. So this was not a controlled trial and it wasn't randomized, so it's quite a small but in-depth clinical study. From that, we identified a number of things. We identified the crucial importance of flexible engagement of people, particularly when they're at a more early stage in their bipolar disorder. So having a very rigid approach to timing and location of sessions, for instance, would be potentially very off-putting. Seemed to be important, and certainly this was the feedback from people in the case series, that giving time to consideration of meaning of diagnosis for people was really helpful. having a constructive review of the sorts of coping skills people were developing, as well as the gaps in those coping skills, was helpful. And also looking at the role of appraisals of fluctuation in mood was helpful. And by that I mean looking at the ways in which people think about their mood changes and how they understand them in relation to their broader sense of self was important in improving outcomes for people. So we had some useful information from that case series to inform the development of the current trial. In terms of the actual therapy manual that we used for the recovery-focused CBT that I'm talking about today, we also did in-depth interviews with people with personal experiences of recovery and bipolar disorder. So we did in-depth qualitative interviews with about 17 people with lived experience of bipolar disorder, asking them about their experiences of personal recovery, how they defined it, what it meant to them, and what factors were associated with facilitating or inhibiting their sense of personal recovery. We also ran a series of focus groups with people with bipolar disorder to consult them on the content, the format, and the supporting materials of the intervention. So we were trying quite hard to ground the direction of the therapy and the modes of the therapy with the wishes and desires of people living with bipolar disorder. In terms of the qualitative work that we did, this identified 4 key themes that people identified in relation to recovery in early bipolar disorder. So I've summarized them briefly in the diagram we're looking at now. And I'll just walk us through the different elements of this. So people identified that having their mood experiences as both understandable and manageable was important in having a sense of personal recovery. And this didn't seem to be about having a particular single model of mood experiences, so different people understood them in different ways, but having a model that was, for that person, internally coherent and linked to a sense of agency with respect to managing mood was important. Seeing recovery as a lifelong process, so seeing personal recovery not as something that you achieve necessarily immediately and then one's in a constant state of personal recovery, but rather that this is a process which can fluctuate, and so that when there are, in a sense, problems with personal recovery, that there are opportunities to move back positively towards it. Access to personally meaningful activity was regarded as important. So for some people, this was about being able to engage in activities or work or relationships that they had been engaged in before becoming unwell, so moving back into things that they had previously valued. For other people, it was very different from that, and it was about moving towards new sorts of activities or relationships that they on reflection really valued now and were quite different from what people had done historically. So the crucial aspect of this was what was personally meaningful to the individual at this time. The other aspect that was highlighted was developing resources to self-manage health, and what people seemed to be talking about there was that there were clearly some periods of time when it was very important to have help, in a sense, come in from outside, from clinicians or from family and friends to help get through difficult periods. But that when those acute periods had passed, it was also very important that the individual was in a position to take more control of what sort of help they would have and when, so that they had a sense of being able to manage that situation rather than have things done to them. So all of those different 4 elements were regarded as important in relation to experience of personal recovery. In terms of our focus group work, we, as I said, had a series of focus groups with people with experience of bipolar disorder. And we took along to those groups an outline of the broad plan of the intervention and then engaged with them around what their thoughts were about key elements that it would be important to include in this to make it a meaningful intervention. They highlighted the importance of a focus on hope and opportunity in relation to the intervention. In line with our findings from the case series, they also highlighted the importance of flexibility of the intervention, so being flexible about where it occurred and also when it occurred and how long each individual appointment was. They highlighted the importance of good quality supporting materials, so not just having the individual sessions but providing people with materials they could take away, including other people's recovery stories so that people can reflect on other people's experiences and draw from those elements that they might find helpful for themselves. They also highlighted the importance of documenting a recovery plan for each person. So in the course of the work done with the therapists, mapping out what was useful in terms of recovery planning for the future, so work that had been done in the sessions that the individual could take forward, and also plans that weren't necessarily executed within the therapy intervention period, but which the person had begun to think about during that period that they would want to do later on, and having a written record of that the person could use after the therapy had finished as they were self-managing subsequently. Also, it was felt that it would be potentially helpful for that plan to be shared with the individual's wider mental health team. That would only be a helpful thing if the client felt that they wanted to do that. So the potential for that was seen as a good thing as long as the individual client had control over whether or not that happened. And the other thing they flagged up was that the importance of measuring functional outcomes as well as symptom outcomes. So measuring aspects of people's quality of life, people's personal recovery, people's social networks, above and beyond the more traditional measurement of patterns of relapse or mood instability. So all of that information was brought together for the version of recovery-focused cognitive therapy that we evaluated within this particular study. The intervention was delivered by mental health professionals who were trained by the BABCP, that's the British Association for Behavioural and Cognitive Psychotherapy, which is a national body in the UK which accredits people from a range of mental health professions with respect to their training and skills in cognitive therapy. So we took people who met those criteria as therapists. The intervention was for up to 18 hours, delivered over a period of up to 6 months. And the sessions were in line with what I've talked about already, flexible, but they were broadly weekly during the early phase of therapy, stretching out to fortnightly in the second half of therapy. So in terms of some of the key ways that recovery-focused cognitive therapy differs from standard cognitive therapy for bipolar, there are a number of ways that I would say it differs. There is an explicit focus on looking at client-focused goals for personal recovery, rather than assuming that the target is always going to be primarily relapse prevention. So relapse prevention can, of course, be one of the targets for the intervention, but the priority for that will be influenced by the goals that the client brings. The intervention is very formulation driven, and by that I mean there's a very individualized approach to mapping out with the person coming as a client how they experience the different aspects of bipolar disorder, and which elements of those they find problematic and which elements they want to have some help with, and how those elements link to each other, so that there's flexibility around the models that clients bring, and we're not particularly trying to impose one model that goes across all clients. We're also happy to look within the therapy at people's day-to-day functioning and their experiences with other issues that can be comorbid with bipolar disorder, as well as mood problems. And by that I mean things, for instance, like substance use issues or anxiety problems that people might bring. So there's flexibility there too. But I guess a key issue is if we're going to be doing an intervention that's supposed to enhance personal recovery outcomes, we need to have a way of measuring personal recovery outcomes. Now, that can be done, as I've illustrated in the previous slide about the different domains of personal recovery. That can be done by in-depth interviews with clients. But I think the reality is, certainly in the UK and I'm sure elsewhere as well, that many clinicians don't have the time to do that sort of interview on top of all the other clinical interviewing in routine clinical practice. We developed, as part of this study, a quantitative measure of personal recovery called the Bipolar Recovery Questionnaire. And this has two potential uses. One, it can indicate patterns of recovery goals that people have quite efficiently. And it also can be used as a measure of whether the treatment being offered is actually delivering recovery gains for people. This is just a paper which we published on the Bipolar Recovery Questionnaire. If people are interested in this, I can forward a copy of the paper to Debbie potentially for circulation. And the actual questionnaire itself can be downloaded from the Spectrum Centre website. So anyone who's interested, if you go to www.spectrumcentre.org and go to the resources page, the Bipolar Recovery Questionnaire is there and it's free to download. And I think actually the paper is free to download from the same point on the site. So that's fairly easy if people want to explore that. In line with people's requests and input in the focus group and in the advisory groups, we developed a series of materials for people called Tools and Choices that ran alongside the intervention. So people were provided with this, and it had 6 sections. So there's basic therapy information, and people kept their own appointment logs. It also had a section on useful information. This was contacts in terms of the therapy, but also wider contacts and self-help groups, and service user poetry was included in that. Again, that was something that came up in the consultation. In section 3, we had a range of anonymised recovery stories, and these were from a range of sources, including the Scottish Recovery Network, who did a great project on recovery stories across a diverse range of experiences, and we were able to identify with their help the bipolar relevant ones in that. In terms of another section people had was where they collected their own information from their experience of therapy, including information on their formulation, mood charts and life charts. Section 5, which was also called Tools and Choices, was where people, if they wanted to, kept their sleep diaries, information on their early warning signs for relapse if that was relevant, summaries of coping skills and their recovery plan. And then Section 6 was future thoughts and ideas, and was completely flexible for people to collect any information there that they felt was helpful in relation to their own recovery story, so that people went away from therapy with quite a comprehensive range of information that they were able to use as they wished for future reflection and self-management. So the study itself is intended to enhance personal recovery. As I said at the beginning, most studies have particularly focused on relapse. So obviously we thought it was important to understand as well whether this had an impact on relapse, because that is in itself a potentially important clinical outcome. We targeted people who had relatively early bipolar disorder, and for the purposes of this study, that was less than or equal to 5 years since onset. These are people who met full criteria for bipolar disorder, but weren't in a current episode when they started the study. We wanted to know a series of things as a result of the study. We wanted to know, because this was the first time the study had been trialled, we wanted to know whether it was feasible or acceptable. And by that we were meaning, if we offer the opportunity to people to participate in a trial of this sort, do they take that opportunity? Do people want to be involved in this? And also, if people do engage with the study initially, do people then engage with the intervention? So do people participate with the intervention over a reasonable number of sessions, such that you might reasonably expect them to gain some sort of benefit from the therapy if there is benefit to be had. In terms of outcomes, we measured, as I've said, personal recovery using the Bipolar Recovery Questionnaire. We used we used what's called the SCID Life, which is an interview measure to measure experiences of relapse. And we also measured other functional outcomes in line with the feedback from the advisory groups and focus groups, so we looked at quality of life and social functioning. So we used the QoL-BD for quality of life, which is a specific measure developed by Erin Mikulak and the CREST team in Canada to measure quality of life around bipolar disorder. And the PSP is a simple interview-based measure of social and personal functioning. In terms of the trial, I won't go through all the detail of this. I don't think it's the most, it's a bit of a crowded slide really, but the gist of this is that we assessed 125 people initially for the trial. The majority of those who didn't then go on to participate either did not meet diagnostic criteria, or were too unwell, or didn't feel they could commit to the time requirements of the study. Because people engaged in the study would be randomized to either receive the intervention or to continue with their treatment as usual. So people in both arms got treatment as usual, but in the therapy arm they got recovery-focused therapy as well. And then people were followed up for up to 15 months in terms of the assessments to get a really good sense of whether anything changed immediately as a result of the intervention, but also whether the gains that people did get, if they got gains with the therapy, whether those persisted after the intervention was complete. So as you can see, that's quite a significant time commitment for people. So it's understandable that for some people that length of commitment was not what they were up for at the time that was considered. But we got 67 people randomized, which was a perfectly good number for this scale of study. In terms of feasibility around the intervention, we had 33 people in the therapy arm, and 32 of those received at least 6 sessions of recovery-focused CBT. So the vast majority of people attended for at least 6 sessions of therapy, and most attended for significantly more than that. So the average attendance was 14.15, so 14 to 15 sessions out of the available 18 sessions. And that compares very favourably with other established forms of cognitive therapy in this area. We developed a measure called the Recovery Fidelity Scale to evaluate the extent to which the therapists were engaging with a therapy which was consistent with their training around recovery-focused CBT. And we found that they were adherent to that for 91% of sessions. This adherence was evaluated by an external therapist. And so it wasn't just us deciding that that was adequate, but so we were confident that it was recovery focused. And we had used something called the cognitive therapy scale to measure the extent to which the therapy was also consistent with cognitive therapy more broadly. And again, that reached acceptable levels. So people were attending for it, and it seems as though the therapists were delivering this sort of intervention that we're trained to deliver. In terms of outcomes for people engaged in the intervention, we looked at, as I say, personal recovery. And here in this bar chart, you can see the personal recovery scores for people at baseline, at 6 months, and at 12 months. And in terms of the different columns, the blue columns are people receiving treatment as usual, and the red columns are people who received the active intervention recovery-focused cognitive therapy. And as you can see, it looks as though people's recovery scores at baseline, before they've received anything, are a bit lower, if anything, in the people who then went on to receive the therapy. But when we look at 6 months, which is just after people have completed therapy, there's quite a substantial difference of better personal recovery in people who've received the therapy. And that difference remains at 12 months. So 6 months after the therapy is finished, people still have elevated personal recovery. So formal analysis, statistical analysis supports better recovery outcomes at follow-up over both follow-up periods in people with recovery-focused CBT. We also, as I say, looked at time to relapse, and this is a survival curve. So if you look at the top left-hand corner of the graph, people who entered the trial were all out of episode. So 100% of people were out of episode at the beginning of the study. And then, as you might expect, over an extended follow-up period, some people did experience relapses of mania or depression, and this graph is time to recurrence of either of those two. There are two lines on the graph. One, the solid line, is people who receive treatment as usual, and the other, the dotted line, is the people who receive recovery-focused CBT. And the key finding here is that you can see that the line falls away much more steeply in the treatment as usual group than it does in the recovery-focused cognitive therapy group, meaning that people were more quick to relapse if they hadn't received recovery-focused CBT in terms of depression or mania. And basically, if you look at those two separately, depression and mania, you find that for depression, the pattern is the same. There's a much steeper curve for treatment as usual, which means people are experiencing a relapse more rapidly compared to recovery-focused CBT, which is the dotted line. And again, if we look at mania, it's the lines are in a different place, but the pattern remains the same, that people are more rapidly experiencing a recurrence of mania in treatment as usual than people who have received recovery-focused CBT. We looked at quality of life, as I indicated. Again, this looks in the right direction. So if we look at baseline, if anything, people's rating of their quality of life is somewhat lower in people who went on to receive the intervention. If we then look at the end of therapy, it looks as though people's quality of life is, their perception of quality of life is better at 6 months if they've received recovery-focused CBT, and that direction of effect seems to be the same at 12 months, although the scale of it looks a little reduced. When we looked at this statistically, the threshold for significance was 0.05. We actually got a p-value of 0.054, so it was just marginally below the standard significance threshold. So it was in the right direction, but in a study of this size didn't formally reach significance. And in terms of social functioning, it looks as though certainly at 6 months people's sense of social functioning had improved, not so much at 12 months, and that change did not come out as statistically significant. So a number of encouraging findings and others which were in the right direction but were not strong enough to emerge as significant. So coming towards the end of the talk, I just wanted to just highlight a few conclusions. I think where we're at the moment is, it certainly seems that recovery-focused cognitive therapy is feasible. So in terms of recruiting people into it, retaining people and engaging them in therapy, the figures that we have indicate that this is definitely worth further exploration. In terms of the clinical outcomes, it looks as though this intervention is promising for improving people's relapse outcomes for both mania and depression. And interestingly, the impact on relapse is at least as strong as it is for interventions that have a primary focus on relapse. So it does seem as though the impact that we have on personal recovery here may in itself be having a positive impact in relation to relapse. So we've had a positive relapse effect, positive recovery effect, and it's in the right direction for quality of life, although not quite significant. But it's also worth flagging up that despite our impact on relapse, so people had fewer episodes and it was a longer time to an episode for people who received the intervention, when we looked at self-rated mood over time, there was no particular influence on just mood itself. So mood out of episode was not significantly different between the two groups. So the main impact seems to be on more functional outcomes and relapse. So I think it's fair to say that the results at the moment are promising for this intervention. And the next stage is to explore this in a definitive trial to give us more precise estimates of the effectiveness of the intervention. And also a crucial thing in the next stage of evaluation will be to test the cost benefits financially of this therapy. But certainly the impact that it has on functional and relapse outcomes, if we repeat those findings in a larger trial, would be really encouraging for supporting this as being a cost-efficient as well as a clinically effective way of approaching this important problem. Okay, thank you very much for your interest and attention, and I've put my email address up here if people want to contact me subsequently, and I'll hand back to you, Debbie. Okay. Debbie, are you there?
Yes, yes. Did you hear the question? I'm sorry.
No, I couldn't hear the question.
Okay, I'm sorry. First question, is cyclothymia seen in these stats or just bipolar 1 and 2?
In this particular trial, it was just bipolar 1 and 2. I mean, it's an interesting question. I think cyclothymia is important, and it would be very interesting to know, how this works with that group of people. We are currently doing a range of studies and would certainly be interested in exploring that in the future. We're also looking at the extent to which this might be helpful for people later on with it adapted. We also have somebody looking at older adults and seeing what its potential benefits may be there. So we are looking at a range of different possibilities with the intervention, and certainly cyclothymia would be something we'd be interested in exploring in the future.
Great, thank you. The next question was asking for the slide that you were going to possibly make available. If you can send that to me so that I can forward that out. The article, I suppose it was?
Yeah, well, that's fine. I can send you, I can send you the article on the recovery measure, and I can also send you the article on the trial itself. we published that in the British Journal of Psychiatry, so I can forward both if that would be helpful.
Okay, wonderful, thank you. And it looks like that is all of our questions. If you have an additional question or something you think about after reviewing the slides, certainly you can email myself or Dr. Jones, as this talk has been recorded and will be archived on our website to share. And I want to thank everyone for joining us, and thank you. There's a couple more questions coming in, actually. If you have a moment. Sometimes it takes a minute to trickle through. Okay. Let's see. I am a scientist and would really love the study. Okay. So that was just relative to what we had already talked about. So again, I want to thank everyone for joining us, and especially you, Dr. Jones, for sharing this insightful information. And I hope to we'll share the articles on our website that he forwards to me, or you can email me at dbrown@ibpf.org to receive those personally. Everyone have a great day. Thank you.
Great. Thanks very much. Bye.
Bye-bye.